Okay, we'll get started. My name is John Grisella. I'm one of the compounding pharmacists at University Compounding Pharmacy, and I'll be the moderator for this program. It's a two days in a row in the afternoon between today and tomorrow. So one half will be today, which will be introduction to hormone replacement, testosterone and female hormones. Then tomorrow, I think, will be thyroid growth hormone, and that should be it for the introduction. And nuts and bolts, which tells you the basic of prescribing information. Just to get an idea of the experience of the audience, can you just raise your hand if this is like the first time you've been to a hormone replacement course? You can see that the interest is very high. If you're interested in getting a very in-depth introduction to hormone replacement, we are going to be in Las Vegas the end of June at the ARIA for a 3-day course, and we'll go through each of the hormones in much more detail than we can go through today. And it's always a great way of starting your education in hormone replacement. Dr. Rothenberg will be one of the speakers. Jonathan Wright, who brought the whole concept of hormone replacement for women, who developed the concepts, will be there. And some of the best speakers we have through the American Academy of Anti-Aging Medicine will be there. So we invite you to come there. If you want to in your blue bag should be a flyer, a postcard that explains it, or if you stop by the University Compounding booth, I've got some information. So our first speaker is Dr. RonRothenberg. He's a graduate of Columbia University. He's been a member of the American Academy of Anti-Aging Medicine since its inception and is one of the premier speakers, and he travels the world speaking about hormone replacement. And so he will be the next speaker for the next hour and a half. His first topic will be Introduction to Hormone Replacement, followed by testosterone. So please help me welcome Dr. RonRothenberg.
Water?
Yeah.
Okay. Thanks, John. We're going to go through the basics of bioidentical hormone replacement. But the first presentation is going to deal with the theory. What are we doing here? How does hormone replacement deal with inflammation? How does this deal with wellness? And where's its place in medicine? Oh, by the way, in your blue bag that you get with the course, there's a CD. That should have all the slides that are presented in the entire seminar, so you don't have to take notes off the slides. And as John said, I've been practicing anti-aging medicine or preventive and regenerative medicine. We sometimes call it for now almost 15 years, and it's just been the greatest experience I've had in a varied career in medicine. And I'm excited that there's some people, this is your first seminar in this field, because this really may change the way you see things and change what you have to offer to your patients. So what's the paradigm shift, the new way of looking at things? Well, aging, the progressive decline in function, mental, physical function, you can deal with this. It can be not completely eliminated, but it can be treated. It can be prevented somewhat and reversed somewhat. And we're not prisoners of our genetic destiny. So if you have genes to have an MI on your 50th birthday, you don't have to go there. You can alter the expression of your genes. Inflammation seems to be the centerpiece of medicine now. Chronic inflammation is the cause of most of the problems and diseases of aging. And it's the cause and the effect. So you've got a vicious cycle. And this is a hormone seminar, so balanced hormone optimization decreases chronic inflammation. You can measure this. You can prove it to yourself and your patients. So another paradigm shift about hormones, we age because our hormones decline, not the other way around. It's not, oh well, we're getting older, of course our hormones are disappearing. That's part of the process of disintegration with age. Paradigm shifts, treating adult growth hormone deficiency is a powerful tool for treating the decline of aging in patients where you can diagnose adult growth hormone deficiency. And we're going to deal with that in depth in another lecture. What about testosterone? It's very safe and can be very dramatic. And in women, bioidentical estrogens and progesterones are safe and also have dramatic benefits. And we'll go through the data on this. Whenever I make a statement, I try to have extensive references in the peer-reviewed literature to justify what we're talking about. And so you'll see as the slides come on in the various lectures, everything will be extensively documented. We're talking about female hormones, and there'll be presentations on this. It should be obvious that progestins are not progesterone. This little assumption, most of us in our training thought they were synonyms. That's how we were taught. That's the basic problem, progestins, with female hormone replacement. And of course, equine isn't human, that should be obvious. Oral isn't transdermal, that's obvious. And there's this E3 estrogen, which is very important. We'll talk about thyroid later, and we're not really treating the lab test, not treating the range of values that we're treating patients. And just because a patient is euthyroid in lab tests, he or she may be clinically hypothyroid, a very important distinction. And we're treating often mild hormone deficiencies. You know, the model we were taught in medical school are just the extremes. You've got Addison's, you've got Cushing's, everyone else is normal, adrenal-wise. But the action in this field is in this vast middle range where you could be at the bottom of the range or at the optimal top end. So we treat adrenal fatigue. We treat mild hypothyroidism, again, with dramatic clinical improvement. Adult growth hormone deficiency doesn't have to be total pituitary failure. You can take someone from the mild stage to the optimal stage. Same applies to progesterone, testosterone. So bioidentical hormones, you know, it's like some critics of the field will say statements like, oh, there's no such thing as bioidentical hormones. Well, it's a word, it's a term, meaning atom for atom, the identical molecule that exists in the human body. So it's just a terminology. And we'll show how we treat deficiency diseases. We're not just throwing hormones at patients. We diagnose a deficiency disease, we replace the hormone that's missing. As a benefit, we'll be decreasing inflammation, and we'll document that we're not increasing cancer risks. Much of the idea of increased cancer risks are myths that are not backed by any evidence, and there are studies refuting this. No increase in heart disease risk, just the opposite. And when I'm dealing with patients, it's a matter of personal choice. I speak to the patient, I find out what his comfort zone is, her comfort zone, and we treat within this. So I'm never trying to talk anyone into anything. I find their comfort zone, and we work within that. The route of hormone application makes a big difference. You can't, again, assume that oral hormones and transdermal hormones will have the same effect. And it's a work in progress. As we gain more information, or if we find out something we're doing is wrong, we'll change what we're doing. Hopefully, we're not stuck in any dogma here. Now, hormone optimization is a clinical specialty, and lab values are helpful. We document what we're doing, but again, it's a clinical specialty, and if the lab and the patient don't agree, I'll vote for the patient. And that's my just training as a clinician. And again, the lab values just are general guides. They should help us confirm our diagnoses, but not make the diagnosis. Some women may be optimized with an estradiol level of 30 or 40. Others may need an estradiol serum level of 200 or 250. So again, patients' hormones are a very individual topic, so we can't have one lab number. It's not engineering. Now, why are our hormones declining anyway? And there's theories that, well, perhaps as we get older, our hormone levels fall off because there's some biological advantage in that to protect us from cancer. But if you think about evolutionary biology, that doesn't really make sense, to me at least, because an animal will either have more offspring and the genome will be increased in the population, or less. Things that happen after reproductive age, such as hormone decline after reproductive age, evolution is blind to this because it's already happened. You've already reproduced or not reproduced. So the concept that your hormones declining help you in some way doesn't really make sense. It's probably the other way around, that the hormones decline because most animals are dead after reproductive age. The concept is that there's no old animals in the jungle, but there are in the zoo. And so modern humans are more zoo animals than jungle animals. So if you're thinking about optimizing hormones, what hormones should you consider? Not that you have to intervene in every single one, but all of them. Because there's interactions and feedback loops and balance. So everything from growth hormone to testosterone to adrenal hormones, DHEA, to higher up on the family tree of hormones, pregnenolone, to melatonin, a key hormone in every living cell, and on, the whole list. Of course, vitamin D has gained tremendous importance in the past couple of years, and I think it's a hormone. By definition, it's a hormone, not a vitamin. It's an endocrine hormone. It's created in one site and travels to remote sites for endocrine effects. So you take a look at lab, and also, how do you feel? Take a look at the patient. Now, if we're talking about hormones, let's go upstream and talk about the most basic hormones that control our physiology, the eicosanoid hormones. A lot of control over these hormones, they're the first ones to occur in evolution. Lifestyle is a big control over them. The idea of you're a one-celled animal floating around in your primeval soup, and you don't have eyes or ears. How do you know what's going on in your neighborhood where the food is? And you send out hormones, and they react, and they return to you, the one-celled organism, and they react with receptors on the cell membrane and in the nucleus, and this is your information about the world. Well, our 30 trillion cells still operate by eicosanoid hormones with autocrine effects. And again, they're very lifestyle dependent, and lifestyle can decrease inflammation. Now, here's our board game. And you can think of some more arrows and boxes for me to draw. Just let me know if I can squeeze some in. Let's take a look. So you want to end up with wellness. So that's at the red box at the bottom. Then you win. You'll lose if you end up with chronic illness. And it all fits together. Where do we start with this? Well, take a look in the middle. You can see NF-κB, nuclear factor kappa beta. This is a centerpiece of inflammation. This turns on the inflammatory cytokines. And in varied seminars that you'll be going through throughout this whole course, you'll keep hearing the same thing. The inflammatory cytokines, TNF-alpha, IL-1 beta, lead to chronic disease, and control of inflammation leads to wellness. So NF-κB turns on these inflammatory cytokines. How do you shut off NF-κB? By the way, shutting off NF-κB is a good way to prevent cancer. We'll take a look. Let's see, the red boxes inhibit and yellow activate. So it's up there. Well, estradiol would activate it, but not if balanced by progesterone. Here's omega-3s, EPA. Let's see. That'll help shut off NF-κB. And what turns on all this inflammation? Look up in the corner. The stress, infection, depression, mind-body connection, high glucose and insulin, lack of exercise. So you see all the negative factors pouring in, creating inflammation, and then vitamin D, resveratrol, all the factors limiting inflammation, and you need to get where you're going. So you may see this diagram again. Now, speaking of inflammation, these inflammatory cytokines are breakdown products of arachidonic acid. As you know, arachidonic acid is the building block of omega-6s. And we're overloaded. You need omega-3s and 6s both to survive, but we're overloaded with omega-6s in our society today. So the arachidonic acid is leading to all these destructive prostaglandins and leukotrienes. They usually have even numbers. Thromboxane A2 leads to vasoconstriction and atherosclerosis. Leukotriene B4 is associated with pain and cancer. So again, if you can steer that whole chart away from inflammation, limit the omega-6s, pour in lots of omega-3s, you avoid this family tree of arachidonic acid breakdown. I'm mentioning this in hormones because these are our basic hormones, our eicosanoid hormones. So even though we have advanced techniques, the basics apply. And got to say it at least once, it's lifestyle is certainly the beginning. It's nutrition, exercise, stress reduction, antioxidants, nutraceuticals. We start out that way. Then you diagnose a deficiency disease. If a hormone's missing, you replace it. If you're going to replace a hormone, as a matter of philosophy and science, make it bioidentical. Put the substance in the human body that we've had millions of years of evolution to deal with and to metabolize. Don't put it in a hormone that is not a bioidentical hormone, because there are no metabolic pathways to deal with it. And This type of treatment is backed up by perhaps more literature than anything else in medicine as an answer to, well, it's not studied enough. And I'll show you just an idea of the medical literature supporting this. So summarizing that, what's the unified theory of wellness? Like, physicists are always looking for a unified theory. Chronic inflammation causes these inflammatory diseases, the diseases of aging, and is also the effect. Anti-inflammation's wellness and balanced hormones is a big tool in anti-inflammation. Some examples. Remember those cytokines, and you always have to think, with a particular treatment and intervention, what does it do to inflammatory cytokines? TNF-alpha, IL-1 beta, IL-6. So cytokine levels, patients age 70 to 90. Higher IL-6, higher inflammation, more death. Higher TNF-alpha, more death. Higher IGF-1, insulin-like growth factor 1, which is our handle on what's going on with growth hormone. Since we can't measure growth hormone associated with life, the relative risk of dying 0.7, 30% less. There's your reference on that. So where's all the inflammation coming from? Why are we flooded with this if it's so bad? And just to put it in perspective, it keeps us alive. And as a surfer, I think aquatic analogies here. If a shark bites you, well, inflammation could be a good thing. Vasoconstriction, that'll help you. That'll help you. You won't be losing as much blood. Of course, the same vasoconstriction when you get a letter from the IRS isn't going to help you. That could lead to an MI. You want fibrinogen and clotting factors high to stop the bleeding. Again, not like you'd want it without a reason. You want leukocytosis, and you want the white cells to migrate to all these gram-negative bacteria that are left over from the shark's teeth, and maybe even though the pain helps you. So acute inflammation keeps us alive. Again, if I'm looking at C-reactive protein, if someone has pneumonia, it's supposed to go up to 100 or 200. So when you're looking at lab tests for inflammation, think, is there a reason for inflammation right now? If it is, that's fine. That's the immune system acting appropriately. So part of this is antagonistic evolutionary benefits, if I get my own words out right. What kept our Paleolithic ancestors alive is killing us now. Example, insulin resistance. Pima Indians in Arizona, 80% of adults type 2 diabetes. This genes that stored fat with carbs probably helped their ancestors survive on a very sparse diet, of desert plants. But fast forward to a fast food diet, the same genes are killing them. So insulin resistance might have helped our ancestors. Anti-inflammation. Some people are more inflammatory than others. Sometimes you do everything to control inflammation, and you're going to get different results. Like, we're all different. Again, high inflammation might have helped our ancestors survive, saber-toothed tiger bites and acute infections. And same thing with thyroid resistance. A lot of people produce reverse T3 in high amounts. We're going to think about that in the thyroid section. Reverse T3 is the stereoisomer which blocks the receptor site. It's helpful in times of famine. Shuts off metabolism, go into a cave and wait till there's some food. So reverse T3 now produces the epidemic of hypothyroidism. Our ancestors might have kept them alive till there was more food. Okay. So we talked about NFKB. Again, this is the centerpiece of inflammation. And as you read journal articles about different interventions and hormonal treatments, there's very often comments on what happens to nuclear factor kappa beta. And decreasing it is a known anti-cancer, anti-atherosclerosis maneuver. So it lives in the cytoplasm, turns on the inflammatory genes, and then gets a vicious cycle going. So you should be aware of that. Inhibiting NFKB results in apoptosis of cancer cells, and it's needed for promoting the inflammatory aspects of cancer. So I want you to be aware of that and take a look at it wherever you can see it. So then some of our maneuvers, our lifestyle and nutraceutical interventions, well, what do they do to nuclear factor kappa beta? Omega-3s. I think of all the nutraceuticals, there's the most evidence on omega-3s and vitamin D at this point. I mean, let's say, they're neck and neck for first place. And maybe some of you have different ideas on that. But anyway, how do they interact with nuclear factor kappa beta? EPA, omega-3s have EPA and DHA, the 20 and 22 carbon chain. So EPA inhibits NF-κB and hence decreases TNF-alpha, one of the primary inflammatory cytokines. Okay, so omega-3s. What about resveratrol? Thought to cause the French paradox, makes every species live longer from yeast to rhesus monkeys and presumably humans as well. Well, resveratrol inhibits NF-κB. So these are also parts of that big inflammatory diagram. It fits in right at the top. What about vitamin D? Inversely associated with C-reactive protein and frailty. So more vitamin D, less inflammation as measured by CRP, and it also inhibits NF-κB. It's funny, C-reactive protein 10, 12 years ago, when we were measuring it, this was considered exotic, I believe, and now it's standard in cardiology. So look how times have changed for the better. So inflammatory cytokines, also the IL-6, IL-1 beta, TNF, produce the acute phase response in the liver. That's where the C-reactive protein comes from. So inflammation, the liver produces CRP, which is more than a marker. It's inflammatory stuff on its own. It's, again, it's part of the immune system. It can keep us alive, but chronically it's bad stuff. Produces fibrinogen. Well, you don't want high fibrinogen chronically. Produces serum amyloid A, which affects the native good HDL cholesterol to turn it into a non-native inflammatory HDL. So aging causes inflammation, youthful hormones protect, and IL-6 is low except as you get older and in emergencies. Now, hormones like testosterone and estrogen downregulate IL-6 gene expression. Okay, so now we're ready for hormones. So is the hormone therapy right for you? Well, shouldn't you be asking a doctor? I am a doctor. Okay. We age because our hormones decline, not the other way around. Hormone optimization treats inflammation. We're going to look at all the hormones. Just an introduction, because there'll be more depth as the seminar goes on. Thyroid. More than anything, thyroid is one of the most emotional subjects in medicine, producing screaming matches in the physician's cafeteria, in the hospital perhaps. And again, treating the patient, not the lab test. And order the right lab test. Is the TSH, well, is that the right lab test anyway? And what's the active hormone and what's the prohormone? Is there a T4 receptor in the human body? I don't think so. It's all T3. And we're treating patients with T4. And again, euthyroid is a tremendous range, not necessarily optimal. More to follow. Testosterone, electron micrograph. Well, when we treat men with testosterone deficiency or andropause, we're treating a deficiency disease. Again, not throwing at hormones at people, diagnosing a deficiency and treating it. So who's got the deficiency? Well, it depends how you define it. The idea of normal for age has to go. I mean, if you're 100 and your hormones are normal for 100, I mean, that's probably not doing you much good. So instead of age-related normals, now we should think in terms of optimal values. Now, Korenman's discussion here in Journal of Clinical Endocrinology, half of healthy men between 50 and 70 have a bioavailable testosterone. We'll talk about what the different terms like bioavailable mean. That would be below that you'd see in a 20 to 40-year-old. In other words, what was thought to be a normal 60-year-old, that same level of testosterone would be sick, would be pathological in a 20-year-old. And since everybody wants the same quality of life and benefits, the 60-year-old has a deficiency disease by this definition. And andropause is a lethal disease. And from head to toe, from insulin resistance and metabolic syndrome to cognitive dysfunction to lower testosterone, increased all cancers. And we'll go into this in more detail. Study in Circulation a couple of years ago linked high testosterone to low mortality. It was a 10-year prospective study, not a treatment study, but looking at endogenous testosterone. Low testosterone predicts cardiovascular disease, and the article points out, paradoxically, treating with testosterone, physicians have been afraid of stimulating prostate cancer, but low testosterone is associated with prostate cancer, not high. And then if you say you play with the numbers and you take a man with a testosterone total of 300 versus 1,000, the one with a 300 has a 57% increased chance in dying at any moment. So low testosterone is dangerous. What about prostate cancer? And we'll talk about this a lot because, of course, the old myth that's been refuted is that testosterone caused prostate cancer to grow. Didn't we all go to the same lecture and the professor said, it's like throwing gasoline on a fire? You know, same professor. We all got around. Well, where did this come from? Was there ever any data to support that statement? Absolutely not. And we'll talk about it more. At any rate, in prostate cancer and hormones, prostate cancer was not related to the serum level of any hormone, of testosterone or dihydrotestosterone or estradiol or the free aspects of these hormones. And we'll discuss a lot of the work by Abraham Morgentaler. And just the summary is there's never been any evidence that testosterone causes prostate cancer to grow. And we'll discuss the paradox. Why do we think, what do we think that, or used to think it? So there's benefits from head to toe. Alzheimer's prevention, perhaps. We talked about diabetes, inflammation, and you can measure the inflammatory cytokines. They're improved. What about female hormones? Again, there's estrogens. There's not just one estrogen. There's no such thing as estrogen. And progesterone and testosterone. And, you know, men are easy. You give them testosterone, they're happy. Women are a little, they're hard. They've got all these hormones and emotions and, gee, all these things we've got to deal with. But you've got to get the right balance. And Terry Hertogs points out there's a delicate balance between estrogens and progesterone, sometimes antagonistic and sometimes complementary. Testosterone in women is a major hormone, and this will be addressed in the women's hormone section that follows. There's estradiol, beautiful micrograph, and of course we've got 3 estrogens, and you know, just those of us dealing with it deal with this every day, but starting out, you have to realize that estrone, the number is kind of built into the name. Estrone has 1 in it, and estrone is already high in menopause. There's estradiol, that's where most of the action is. That's got the di in it, and there's estriol, that's got the tri in it. That's the weak cancer protective estrogen, that's sky high in pregnancy. So we have to consider what's going on with these. Cutting to the chase here, does bioidentical estrogen and progesterone replacement therapy increase the rate of breast cancer or cardiovascular disease? Well, no and no. And interestingly, just this week, the Women's Health Initiative follow-up study came out. Did you see that? It took a look at women who just got Premarin, CEE, who had hysterectomies, who didn't have progesterone, because that's not the way we recommend doing it. But at any rate, they will see how long did they take it and what happened after they stopped and what happened in different age categories. The bottom line was there was approximately 20% decrease in breast cancer even with the evil, quote unquote, Premarin. So imagine how good we can do with the right hormones. So check that out. So is breast cancer increased? No. Lab test versus clinical picture? Take a look at them both. Does she need progesterone after hysterectomy, contrary to what we were taught? Yes, every cell in the body has a progesterone receptor. It's a major hormone. Why wouldn't you include it? There it is. And the problem with female hormones, cutting to the chase, has been the confusion between progestin and progesterone. They're not the same. In fact, progestin blocks most progesterone receptor sites. So here's the antagonism and the synthesis where they come together. Estrogen can cause fluid retention, and progesterone's a natural diuretic. Estrogen's sympathetic, progesterone's parasympathetic. It's nature's built-in GABA receptor for tranquility. So this Women's Health Initiative study turned everything upside down with hormones. But everything was wrong with the study, basically. They used the wrong estrogen. Now, why would you think of putting equine estrogens in a human species? In human females? What possible logic could there be? Since bioidentical human estrogen was even available at the time. Come up with your own theory, which probably is something like follow the money. But even the idea doesn't make sense from the beginning. And it's not a human hormone. There's all these horsey sounding things in it, equilin, equilinin. And there's almost no E2 estrogen. That's where the action is. And there's no E3. That's the cancer protective one. And then, again, there's no progesterone. It was progestin. And oral estrogens increase inflammation. Transdermal, non-oral do not. And it was older women, already had cardiovascular disease, on and on. So that study that changed all of medicine, I think just about everything was wrong with it. Again, oral estrogens increase inflammation and transdermal don't. So that's an important point. And a lot of the problem with oral estrogens, increased intravascular coagulation, has to do with inflammation. Here we go. Oral CEE equals Premarin. CRP increased 192%, and IGF-1 decreased. So it's a major metabolic problem using oral estrogens. Transdermal estrogens decrease inflammatory cytokines. See, we keep seeing them over and over. IL-6, TNF-alpha. Now, E3 is safe and effective. Again, that's the hormone that's very high in pregnancy, which is not in conventional commercial estrogen replacement therapy. Now, the mechanism of protection of E2 may be through metabolic downstream products, the methoxyestradiols. And why was the big difference? The literature speculates, how come there was such a big difference between the Women's Health Initiative and what every study before that observed with estrogens? And it has to do probably with the 2-methoxyestradiol. It's anti-proliferative, apoptotic, anti-cancer, anti-atherosclerosis. So you can see 17-beta estradiol can go in a few different directions. If you go up to the top of the slide, CYP1A1 gets you 2-hydroxyestradiol. Then through catechol or methyltransferase, you get what we want, 2-methoxyestradiol. Now you remember COMT from biochemistry? That's used for metabolizing catecholamines, epinephrine, norepinephrine. So this might be part of the mind-body connection, the biochemistry of it. High stress, high adrenaline, your COMT gets used up on metabolizing the adrenaline, and you don't have 2-methoxyestradiol. So we all know of cases where high stress, cancer seemed to follow somewhat. This could be part of the biochemistry of that reaction, the lack of 2-methoxyestradiol. More on that later. So we want to balance these hormones, and every woman has a unique balance. You can't assume one size fits all to teach the patients to balance it. Now, where's the data? Your colleagues may say, well, you're saying this, that there's no increase in cancer. And where does this come from? Well, you can't look to the WHI because you measured everything wrong. So let's go across the pond and look at European studies. Here's the Fournier study from 2007. 80,000 postmenopausal women, teachers. Sometimes the criticism of the study is, oh, well, they were French. But I don't know, whatever that means. Okay. Anyway, women treated with bioidentical estradiol and progesterone, there was no difference in the breast cancer rate from the background. Some of their earlier studies, there was actually less. But if MPA or Provera was used, there was a relative risk of 1.69, 69% increase in the risk of breast cancer. So, see, the progestin is where the problem is, in my analysis. Other studies showing how the more progesterone a woman's exposed to over the duration, the less risk of cancer. That's the Campagnoli study. Some of these slides I'll just pop up here. You can read the study later if you want to. Shira, no increase in mortality from cancer with estrogen replacement. Again, we've got the current Women's Health Initiative one. A few other studies showing estrogen decreased the risk of mortality in patients with breast cancer. So, less death in breast cancer patients on estrogen. Now, just a little explanation and part of this paradox. And the beginning of this idea came from Dr. Mahmoud. It's the estrogen in the breast where the action is, not in the serum. And so there's a lot of things. This kind of represents what's going on with estrogen metabolism in the breast. See, here's E2. Now, we know that if you take a petri dish and have breast cancer cells, it'll cause mitosis and proliferation. But in vivo is what counts. So if you block aromatase, and there's a lot of natural ways to do this, melatonin, etc., there's less E2. Or if you block aromatase here, androstenedione doesn't convert to E1, which is weaker than E2, and then E2. Now, more of the action here is between E1 and E2. 17-beta-hydroxysteroid dehydrogenase has a whole family of isoenzymes. But the main ones, if you can go take E1 to E2, so you're getting a weaker estrogen to a stronger one. So if you can block this, there's less estradiol in the breast. What blocks this? A lot of nutraceuticals, pomegranate juice, etc. So we have a lot of nutraceutical treatment that blocks 17-beta HSD. Now it even gets more interesting. E2 and E1 both have sulfated forms, which are not active. So if you can turn on the arrow that goes from E2 to E2S, okay, the sulfotransferase, and you can inhibit the sulfatase, the bottom arrow, then you'll have less estradiol in the breast. And guess what? Estradiol itself is a sulfatase inhibitor. Progesterone, P4 is the abbreviation, itself is a sulfatase inhibitor. So systemic estrogen, estradiol, and progesterone can decrease estradiol levels in the breast. That's kind of explains part of this counterintuitive business. Just wanted to refer to that here. Growth hormone we'll have a separate session on, and we stop making it as we get older. And there's some controversy, but some population studies, and we'll discuss those. But if there is growth hormone deficiency, replacing growth hormone maintains adult health. We'll talk about the binding proteins. When you treat a patient with growth hormone, you're increasing IGF, if the liver makes it, and also a family of IGF binding proteins, which are hormones in their own right. IGF binding protein 3 is an anti-cancer hormone in itself because it turns on the P53 gene. So this is how a balance is produced. Quality of life, again, you compare a 20-year-old to a 60-year-old. The 60-year-old's level of IGF-1, reflecting growth hormone, would be much lower than the 20-year-old's. Why not have the same standard of health for everyone? Growth hormone deficiency causes decreased longevity in humans. I mention this because there's a lot of rat studies people always are asking me about, compared to siblings if they're missing the gene. Replacing growth hormone improves everything from head to toe, from cognition to body composition to cosmetic experience. No increase in cancer rates with growth hormone replacement therapy. Again, we will discuss this in more detail. CRP, it's lower. It's anti-inflammatory. So you should know your inflammaging numbers. Everyone know their CRP? What do you have here for your CRPs in the front row? You know your numbers personally? Yeah, well, 0.8. Anybody beat that? What you got? What was that? Okay, you said less than 2 for cardiovascular risk is saying you're reading off the lab slip there. But what's the difference between high sensitivity? You're well, okay, good, I can pick on you. What's the difference between high sensitivity CRP and regular CRP? Is it the same lab test, but just has more decimal points? It's the same lab test. Just before old-fashioned CRP, it was 1, 2, 3. Now you've got decimal points. That's why it's called high sensitivity. So less than 2, less cardio. But is less than 1 better than less than 2? No data. No data, he says. I think, okay, that's we can agree to disagree on that. I think there is a sliding scale on that. But it's great that we have a cardiologist here to voice their opinion. So CRP. What about your fasting insulin? That's related to cancer risks besides obvious metabolic syndrome, diabetes. Anyone know their fasting insulins here? What you got? 8. That's pretty good. What do type 2 diabetics usually have? Like 10, over 10, yeah. The 25, the lab says over 10, I get concerned. Anyone beat 8? Okay, they're not telling. The HIPAA, please. What about homocysteine? That in the cardiology literature, there's one article saying the death of homocysteine. But it's inflammatory stuff. How are your homocysteines running? 12? That's lab. I'd like to see it 7. What about omega-3s? How can you measure your omega-3 status? You can take a look at your triglycerides. That gives you a clue. But how about your AAE-EPA ratio? You know, traditional Japanese are less than 1.5. Eskimos, Inuit are less than 0.7. And of course, everyone here should know their 25-hydroxy vitamin D levels by now, right? What do we got here on this side? What's your vitamin D levels? Front row. 25? 45. Well, you're not drastically insufficient. 18? 18, you're barely alive. You know, you can make, you can make 25,000 units of vitamin D in a day yourself if you play volleyball in a bikini in Maui at noon and don't take a shower till dinner.
As long as you're less than 50 years old.
So I think that what the vitamin D literature is getting at now is really the optimal range is probably 80 to 100. And it's the easiest thing in medicine. Just take a pill, or if you don't want to stay in the sun. And then you should know your cytokines. You probably don't know them now, but maybe next year when you come back, you'll have those levels for me. So this is our introduction, and now we're ready to go in a minute. Joe's got some comments here, though.